So hello, everybody, welcome, and thank you very much for joining what is the third in our webinar series, our lunchtime webinar series today. My name is Helen Bolton, and I'm the Communications Officer at the Centre for Academic Primary Care at the University of Bristol, otherwise known as CAPC. In this webinar, we're inviting you to think about how we can improve primary care for people with multiple long-term conditions. And we'll be hearing from 4 speakers today. Professor Chris Salisbury, a GP and Professor of Primary Healthcare at CAPC, who has been conducting research on multiple long-term conditions over the last 10 years. Dr. Rachel Johnson, also a GP and NIHR Clinical Lecturer in Primary Healthcare. Rachel will then be followed by Dr. Cindy Mann, a Research Fellow and a Practice Nurse and Rheumatology Nurse Specialist by background. And finally, Dr. Claire Lake, a GP in Manchester and Medical Director at NHS Greater Manchester Integrated Care Board. Chris, Rachel and Cindy will be talking about research they have been doing in this area, some of it current, and Claire will be sharing experiences of implementing interventions to improve the care of people with long-term conditions in the Greater Manchester area. For the Q&A session at the end, we'll be joined by Professor Richard Byng, who is Professor of Primary Healthcare at the University of Southampton and Deputy Director of PENARC at Peninsula Medical School. And just a few housekeeping points before I hand over to Chris. We are recording this webinar and we will make it available on our YouTube channel after the event. You'll be muted and your video off throughout. Please use the Q&A as questions occur to you, and you can do that at any point during the webinar from now. And we'll come back to these during the panel discussions. We'll obviously try to answer as many as we can. We may not get through all of them. You can upvote questions by clicking on, I think there's a thumbs up or a like symbol. And you can use the chat for comments, or if you have information that you'd like to share with people that you think would be useful, or if you've got an admin question, which we'll try to answer if you're having difficulties. Finally, if you're a friend of Twitter, it would be great if you could tweet about the event using the hashtag CAPC webinar. So that's it. I shall hand over to Chris now, who will start the day's proceedings. Thanks, Chris.
Thank you, Helen. That's great. And I'm Chris Salisbury, and it's my job to set the scene in this seminar where we're thinking about how primary care can improve the way it responds to the growing number of people with multiple long-term conditions, because the changing nature of the patient population with more and more people with multiple long-term conditions is probably one of the biggest challenges facing general practice today and primary care today. For those of you not familiar with this whole topic, when we talk about long-term conditions, we mean things like diabetes, asthma, heart disease, high blood pressure, depression. And these things are common and they're getting more common. In the seminar today, as I say, I'm setting the scene, and then after that, Rachel's going to tell you about how we're offering general practices some tools to provide a new way of working in the personalised primary care for multimorbidity study, or PP4M for short, and how we're going to study how that process of implementation works. And then Cindy Mann is going to present the Maxwell study, which builds on the PP4M study in that it offers practices the same tools, but in a small number of practices, we're investing in them more heavily by working with them to do some co-production with their local communities, and also funding them to get extra training from the Year of Care partnerships. And then Claire Lake is going to tell us about the experience in Greater Manchester of trying to make a similar move to more holistic care, personalised care. And finally, we're joined by Richard Byng in a panel to answer your questions. Well, we've only got an hour, and I'm going to keep going. So many people have got multiple conditions at the same time. And having multiple conditions has a big impact on your health. This won't be any great surprise. People with multiple long-term conditions or multimorbidity tend to have a poor quality of life. If you have multiple physical health problems, you often have poor mental health as well. And these patients don't just have problems with their health, they also have big problems with the healthcare system. They spend a lot of their time trying to juggle appointments, ending up on complicated drug regimes. Often they find that their care is poorly coordinated, and it's not clear to them that any one doctor or nurse is taking responsibility for looking after them. How does it feel to be a patient with multiple long-term conditions? This quote comes from an earlier study from London. I remember one time I went to the GP and I had 3 different problems, and they said, "No, sorry, you need to go and make another appointment and come back." I was really annoyed. They could at least hear me out, because I'm not pretending. I've gone there with a serious problem. So increasingly, general practices are trying to treat people as if they've got one problem at a time, when many people have got lots of problems that they need to talk about. And that's frustrating for patients. And this is a growing problem. About 1/4 to 1/3 of adults in England have got 2 or more long-term conditions, and the number of long-term conditions increases with age, so that more than half of those aged over 65 have got 2 or more conditions, and 1 in 10 have got 4 or more conditions. And the number of older people in the population is increasing quite rapidly. So by 2035, it's estimated that the percent of the population over 65 with 4 or more conditions is going to almost double. And about 1/3 of those will have even more complicated problems, because they will also have mental health problems or dementia. So this is a tsunami of complicated problems that's hitting healthcare and hitting patients, of course. And these people are big users of the healthcare system. This shows the number of consultations in outpatients, in general practice, and number of prescriptions according to the number of conditions people have got. And if we focus on the GP side of things, you can see that someone who's got 4 or more conditions consults about 24 times in 24 months, so about once a month. So they make up a big part of the workload of general practice. And although we haven't got data from this study, you can be pretty sure it affects social care as well as healthcare, the same phenomenon. And yet, I think that the way we are moving in providing primary care is in tension and almost going in the opposite direction from the needs of the patient. It's in that over the patients increasingly have got multiple diseases, and yet primary care is increasingly trying to treat people as if they've got one disease at a time. And why do I say that? Well, over the last decade, we've increasingly segmented care by disease, designing care pathways and running review clinics for each disease in isolation, managed by nurses who specialize in that disease. And they use guidelines and checklists based on one disease at a time. So the consequence is that the same patient can get called up multiple times in the same practice to review each of their conditions one by one, when they get repeated appointments to see different people who recommend different things. And when they go to normal routine consultations, they're told that they're going to talk about one problem at a time, but that might not necessarily be the biggest problem that's affecting them at the time. And I think that this whole approach is inconvenient for patients. It leads to poor coordination, it's inefficient for practices, and most importantly, it's not patient-centered. It's not responding to the needs of the person in front of you. I think this is a classic example of trying to design patients to fit the system rather than designing the system to fit the patient. Now, lots of people have recognized that problem, and there have been a whole load of reports, and fortunately, they all tend to come up with the same kinds of recommendations. That we should review people as a whole, we should focus on their personal individual needs, we should support them to manage themselves as far as possible, improve coordination of care, and try and ensure that they have someone who's clearly responsible for them that they trust, try and simplify the number of drugs that they take, and to pay attention to mental as well as physical health. And there's a lot of consensus in reports. Now, whenever there's a consensus in lots of official reports like that, you can be pretty sure that researchers like us come along and want to study whether it actually works. And this is no different. And in fact, there have been a number of trials of interventions of this kind of approach, including one of the biggest, which we did in Bristol, the 3D trial. And what have we learned? Well, there was a systematic review of 16 trials like this, and what it found was little or no evidence that this kind of approach led to improvements in people's health-related quality of life or mental health. Mixed results on most other outcomes. Some suggestion that better care coordination can improve patients' experience of care, and that self-management support can improve their patient health behaviours. But overall, mixed results, and the certainty of evidence is fairly low. So these all sound like sensible ideas. Everyone says they're a good idea, but when you try to do them in research studies, you find that you don't necessarily pick up the benefits that you're hoping to get. Why might that be? Well, One reason is because research is very different from what happens in real life. In research, you're asking practices to change care for a small subset of patients who are giving consent to take part in research, while at the same time, the practice is continuing to provide their usual way of care for all their other patients. And they've been providing that usual way of care for many years, and they know what they're doing. And for their new approach, they've got to learn new skills and attitudes and use new computer software and reorganize how they make appointments. And if, like me, you've bought a Mac computer when you spent 30 years working with Windows computers, it's very, you know how difficult it is to learn a new way of working when you're in a hurry, and how tempting it is to just go back to the way you've always done things. So there are just so many things that all need to be changed at once, and so many moving parts. And what we found in the 3D study is that only about half of the patients got the new types of reviews that we intended. And even then, they didn't necessarily get the reviews in the way we intended. So perhaps it's not surprising that not much changed. So we've decided to go back a step and do a different kind of research, a study of implementation. How can we help practices implement a new way of working? What makes it difficult for them? What would make it easier for them? What are the motivating factors that make them want to change? And some practices do better than others with changing the way they do things. So trying to understand how do the successful practices do it and what lessons can we learn? And that's the kind of research called implementation research. And that's what Rachel's going to tell you about next. Thank you.
Great. Thank you very much, Chris. So I'm Rachel Johnson. I'm a GP and a researcher at the University of Bristol, and I'm going to talk about the PP4M study, personalised primary care for people with multimorbidity. So Chris led the 3D study, which showed us that computer templates can be used to support person-centred care. And PP4M focuses on how such a template can be integrated into routine primary care practice. So we're studying the implementation of the template, and we're doing this in 16 GP practices across 3 sites in Bristol, West Midlands and Wessex. So people with some long-term conditions are invited to their GP surgeries for an annual review appointment, and traditionally these reviews have been done separately for long-term conditions. Staff in GP practices routinely use computerized templates in appointments, including in these annual reviews. And those computerized templates are used to structure the consultation. They prompt the practitioner to ask certain questions and collect and record certain information. And we've worked with an existing template provider, Ardens, and also the Year of Care organisation to develop one of their existing templates so that it can support person-centred annual reviews that can be used to review all of a person's long-term conditions in a combined review, which is potentially more efficient for both the patient and the practice. So our template enables that combined review of all the person's long-term conditions, and it's smart, so it only shows the conditions that are relevant to the individual person. It's vitally important to GP practices that they can collect information in a way that will ensure that they meet the quality and outcomes framework requirements, and the template supports this. But it also attempts to focus the consultation on what matters to the person living with the long-term conditions. It's holistic, so it includes quality of life, functioning, well-being, mental health, memory falls, medication concerns, as well as the specific disease-related questions. And it supports social prescribing and shared decision-making and leads to the development of a care plan in which the person's priorities can be documented and agreed goals recorded. And the template can be used to support a 2-stage review process. So in the initial consultation, this is usually healthcare assistant led, and information relevant to the different conditions that a person had is collected, and disease surveillance checks are done in that initial consultation. After that, the patient is sent some preparation materials, and these include the results of the tests and checks that they've had, including blood results, for example, some information to help them understand what those test results mean, and also some prompts to consider, to think about their health and well-being. And we're using documents that have been designed by the Year of Care Partnership to do this. So they help the person to consider what is most important to them that they would like to discuss in their annual review consultation, and also gives them prompts for a wide range of things, for example, sleep, relationships, loneliness that they might want to talk about that are really important to them. So this then leads to the second stage of the review process, the annual review, in which you now have a prepared patient meeting with a healthcare practitioner, and together they can have a conversation, review how the medical things are going, consider what's important to the patient, and develop a care plan. This is an implementation study. So we have had an implementation package that we developed, which aims to support practices to get the template into practice. This includes a set of resources which explain the potential benefits of the intervention, both to patients and to practices, and in detail describes what's required of practices. There's also an Ardens training webinar and support with the IT tools that we've developed to help this implementation also. And I'm going to go on to talk about practice teams and process mapping in the next couple of slides. So one of the key elements of our implementation strategy was to engage practice teams, a core practice team to support implementation. And this so far has been challenging. It's important to say the research that we're doing is at a very early stage. So there's still lots of learning to be gained, and we're just sharing really our kind of initial findings here. But engaging the practice teams has been challenging. We envisaged that a core team might include a GP, a practice manager, a receptionist, an administrative person, a nurse, possibly a pharmacist. So all of the people who might in some way be involved in these reviews. But in reality, we've been working with small teams, sometimes only one or two people. It might be, for example, a practice manager and a nurse who've been tasked with implementing the reviews in their practice. And these small teams can be quite vulnerable, for example, to staff sickness or staff absence. GPs have actually been involved very little in determining how the reviews will work in their practice, although they are often involved in deciding that their practice will take part in the study in the first place. We've been met with a lot of enthusiasm for person-centred care, but this hasn't always been shared by all of the members of the team. We've got some practice, for example, whose nurses have been really seen the value of practicing in this way, but have not joined the study because the GP partners haven't necessarily shared that vision. And lots of practices, as you would expect, have been affected by staff sickness, including COVID, and very high workload pressures. So it's been challenging for teams to find the time to drive implementation. Another core component of our implementation strategy is process mapping. So we've been supporting practices to do a process mapping exercise where they think through the detail of how the template will work in practice. And it's evident from doing this that the template is a complex change that affects many interlinked processes in the practices. For example, they've had to think through who to invite and how to invite them. Do they invite all of their people with multiple long-term conditions or just a subset? We're focusing our evaluation in this study on people with 3 or more conditions, but the template can be used to review anyone with multiple long-term conditions. But some practices have continued their usual review process alongside these multimorbidity reviews, which has added complexity. Some practices have chosen to focus on a subset of conditions, and that decision has usually been made because of workforce and skill mix issues within the practice. They've had to think about the patient preparation materials. Do they send them to everybody? If so, when? Do they include the blood test results? If so, do they need a process within the practice where someone has to review the blood test before they're sent out to patients, for example? They've had to think about the first and second appointments. Does everybody need the first? Does everybody need the second? Or do some people with some conditions perhaps just need one of those two? And the skills of the healthcare practitioner team has really underpinned all of these decisions. An example, in one practice, they didn't feel they had anybody who could do the combined review. So they considered running it more like a clinic and having patients see multiple people in one visit to do the different parts of the template. So as I've described, there's been a really wide variation in the practice processes and how they've decided to implement the intervention. We have to talk about staff roles and the absolutely pivotal role that nurses and healthcare assistants take at the moment in the provision of long-term condition care and long-term condition reviews. And the skills for multi-morbidity reviews sometimes reside in a small number of individuals. And again, this creates some vulnerability in the practice team. And we've observed really different understandings about who has the skills to do these holistic long-term condition reviews. Some people have felt that healthcare assistants have the skills required to do this, while others feel that it has to be nurses, and sometimes nurses with highly specialised training for some particular conditions. So there are challenges. We're researching a service change, and there are some challenges inherent in that. This relatively simple intervention has proven to be complex in practice, and the research processes add to that complexity. Possibly because it's within a research study, some of the practices might have less ownership over these changes and see them as temporary. And I've described how the intervention is certainly adapted in practice, and that gives us some complications when we're trying to measure the impact of these changes. But so far, we've developed really crucial insights into how this is working in practice, and we're excited about what we'll learn as we carry on with our evaluation. And we are running this an evaluation in 16 GP practices across 3 sites in Bristol, West Midlands and Wessex. And it's going to include interviews with patients and staff, videos of consultations, questionnaires for patients and staff, and some routine collected medical data to answer some of these questions that Chris posed earlier in his talk about implementation. So now I'm going to hand over to Cindy Mann, and Cindy is going to tell us about the Maxwell study. The Maxwell study is a subset of the PP4M study with a specific focus that Cindy will tell us about.
Thanks, Rachel. I'm Cindy, and I'm leading the Maxwell pilot study. Maxwell stands for Maximising Wellbeing in Everyday Life with Long-Term Conditions. And the project arose, like PP4M, from Chris's prior trial, the 3D study, for which I conducted the process evaluation. Maxwell involves 3 GP practices in the Bristol area. 2 of those are small and serve a very deprived area. And the third is about twice the size and in an area of medium deprivation. The aim of this pilot is to see what difference it might make if practices are given more support to set up the intervention, including additional training, and also whether localised community consultation might perhaps be a useful approach to addressing health inequity. So the core principle for Maxwell is partnering with patients in their healthcare. Practices will use the same Ardens template that Rachel described and the same review structure with a focus on well-being and what matters most to patients. There'll be a particular emphasis on how to support self-management, recognizing that the key role of the person with the conditions in managing them has the key role in managing them day to day and has to live with them. The main differences between Maxwell and PP4M are, firstly, the additional training that practices will receive, provided by Year of Care Partnerships, who've developed personalised care and support planning in GP practices over many years. And this training emphasises the ethos of partnership with patients and the skills that health professionals need to look beyond the individual diseases and review of those, and work out with patients what might make the most difference to their well-being and how they can be supported to improve that, whether by the healthcare service or within the community, and including professionals like OTs, I just saw the chat question about that, and social prescribers and anyone who might have the relevant skills to help with that individual. And then the facilitated process mapping session helps the practice to think through the changes that they might need to make to implement the new system and to plan how to do that. And then, as Chris mentioned before, we're engaging in community consultation with that increased focus on the patient perspective. So we want to find out from the local communities served by the practices what might make the new service appealing and accessible to them and might make them feel more likely to use it. And we'll feed their views back to the practices so that they can, if it's feasible, adjust how they're implementing the reviews, considering things like timing of the reviews, how people are invited, choice maybe over mode of consultation. And we're hoping that this might help in a small way to address health inequities. As well as community engagement, we've also worked very closely with our PPI colleagues during the development of this project, and they've given us really valuable input. And they confirm that people do want care of this kind. So they do want more time, and for it to be easier to make appointments, as I'm sure you would all agree, and for those appointments also to be long enough to discuss everything they want. So they need a certain amount of flexibility, which can be quite difficult. They would ideally like to see someone they know, and for their care to be joined up and to receive information that is useful to them. But they also identified some possible barriers. So they weren't sure about how patients might interpret the change. Might people feel less supported if they're asked to take on more responsibility for their own health, for example? Or in the words of one person, might they even feel abandoned? Will they know enough to self-manage? And would they have all the information that they need? Health literacy may be involved here, and people may lack enough knowledge about health or enough confidence to advocate effectively for themselves within the system. Additional barriers may be the traditional ways that patients and health professionals interact. The idea that health professionals perhaps expect patients to defer to them and might react negatively to people if they turn up with their own data or ideas about what they need for their health. And then, of course, there's the health system agenda that focuses on the information that it needs and the advice it's required to give, rather than on the individual person's needs at that moment. We've also been talking to health professionals and received some really valuable feedback and suggestions from our healthcare professional working group, which consists of a GP, several nurses and a pharmacist, as well as from the Maxwell practices during the year of care training. Primarily, they want to be able to provide, of course, the best possible healthcare, and they would like to be collaborative and holistic. Many do see that way as potentially more rewarding and more efficient, and it is how they would like to practice, as well as seeing it as an improved model of care that's probably better for patients. And health professionals would, of course, like patients to take more control of their health. And generally, they would see that as following the self-management recommendations that they give to patients. But they question whether patients have enough resolve to do this sometimes, and also their capacity to take in all the necessary information, particularly on one occasion. And nurses in particular do worry about their professional responsibility and accountability if they're unable to cover everything they're aware they should due to following the patient's agenda, or if they lack expertise in one or more conditions a patient may have. So, as Rachel said and Chris has said, this is a big change. It's one that people want, they definitely want it, but it is very challenging to achieve. And we think we've identified these important steps that we think are necessary to make this change. Firstly, practices need to recognise that this is a whole team change. It involves not just health professionals and particularly nurses, but also the admin and reception staff, those who are responsible for making the appointments, for explaining the system to patients, and who are responsible for the supporting IT as well. So it needs to be planned as a team, listening to the concerns of all colleagues and to their experience in their own particular areas and expertise, and with a willingness to arrange additional training as needed. So training is a key part, and it will take time to set up and establish and acquire the new skills. It will also require time, and I know this is a luxury that's in very short supply, but it will also require time to fit in the longer appointments that we're hoping will save appointments longer term. So expectations do need to be realistic about both how long it will take and what will be needed to establish the change. And patients obviously need to be brought along with the change as well and be prepared for it. So they need to know in advance and ideally be consulted about the planned service change and what to expect in a positive way so that they can play an active part in it. And this is in addition to the individual preparation document that Rachel described, that contains their results and prompts that they get before the second part of their review. So support is crucial from both within the practice and the local healthcare system. The nurses and healthcare assistants need to be supported to develop the extra skills with additional training, feedback, mentoring, and peer support possibly. In one practice, for example, they've just decided to offer extra consultation skills training to their nurses. In another, a GP is offering training in management of respiratory conditions where these are lacking. The local NHS training hub could also perhaps offer support with additional training in generic holistic consultation skills, so nurses and HCAs feel more confident in this approach and that it's approved and legitimate. And perhaps the ICB has a role to play with structural support. So if I were to summarize in 5 words what's needed, I would say the whole team, training, support, and determination. I'm confident that 2 of our practices, although they're facing huge challenges, will achieve this change because they're working closely as a team with support from their PCM, and they are determined to make the change. So just before handing over, I'd just like to thank our colleagues in the ARC's West Midlands, Wessex and Peninsula who are working with us on the PP4M study, and the NIHR who are funding this project via the ARC Priorities Fund, together with the NIHR School for Primary Care Research and BNSSG ICB, Integrated Care Board. And now I'd like to introduce Dr. Claire Lake, who's Medical Director at NHS Greater Manchester Integrated Care Board, who's going to say something about their experience of promoting holistic person-centred reviews for patients with multiple long-term conditions. Thank you, Claire.
Thank you, Cindy. And I will just go back to the first slide. So yes, I'm here to share the work that we've been doing in Manchester. And I think it's fair to say we've approached this from a different perspective, I think, but have reached a very similar place that Chris, that Rachel and that Cindy have described. So I am speaking about work that we've doing within the Manchester locality of Greater Manchester. So this was previously known as Manchester CCG. 10 CCGs have come together as an integrated care system. And the work that I'm doing is within the Manchester locality. So our Manchester population is 600,000 of the 2.8 million in our GM population. And we have 83 GP practices within our Manchester locality, organised into 14 primary care networks. And we're a really diverse city with over 200 languages spoken. But we do have considerable and long-standing deprivation and inequality. We're ranked 6th in the National Index of Multiple Deprivation, and pockets of our city rank higher. We are really proud, though, to be a Marmot City region. And what that means is, as a city, our public bodies have all absolutely signed up to tackling those determinants of health. So education, employment, housing, and how those things impact on our health outcomes. But we do have really significant health challenges. And the slide is split into the left side, which is pre-pandemic, and the right side, which is post-pandemic. So this chart on the left, the premature death slide, so this shows that Manchester as a local authority area was 150th out of 150, so bottom of the pile for premature deaths from heart disease and stroke and from lung disease. And we were 149th out of 150 for cancer premature deaths. And that was pre-pandemic. I think we all know the impact that the pandemic has had on health and health inequalities. And what we tried to do in Manchester was to find some data to really understand the impact that the pandemic has had, and particularly around cardiovascular disease. So this chart at the top shows the leading causes of death, but plotted by wave of the pandemic. So you can see the red line, which is COVID, goes up and down with wave of the pandemic, but also then really drops off with the onset of the vaccination program. But the purple line, which is cancers, and the blue line, which is circulatory diseases, and the green, which is respiratory, although to a lesser extent have been very present throughout the whole of the pandemic and continue to be a real challenge for us. I think, you know, I'm a GP, and I know there'll be lots of clinicians on the call, and we all in our consulting rooms have seen people with worsening long-term condition disease control. And we wanted to try and put some evidence behind this in Manchester. So we just did a really quick piece of work that looked at different long-term conditions and looked at the change in disease control over a time period. And I wanted to just share the diabetes data with you. So this shows that in December 2020, we had 9,400 patients who would fall into the category of having poor diabetic control, compared to 13,000 a year later. So it was really clear to us that we needed to find a new way to support general practice in the long-term condition kind of catch up and recovery post the pandemic, but we also really needed to continue and increase our focus on tackling health inequalities. So we reviewed QOF, both in terms of the ask of the scheme, but also our local achievement data. We reviewed the PCN-DES and the Impact and Investment Fund, the Core 20+5 framework, and the local and the national COVID-19 recovery priorities to really try and find an angle that we could come at locally that complemented all of these national things, but gave us a new way of working within Manchester. And what we came up with was something called the Manchester Primary Care Quality Recovery and Resilience Scheme, that launched in April of this year. It's a funded scheme for Manchester General Practice, and it's worth just short of £7 million. And the aim is that we use that money to support practices to reduce unwarranted variation, to tackle the inequalities we see in our health outcomes, and to really give some support to general practice in the recovery from COVID. So the scheme has multiple sections, but one of the key components of the scheme is asking general practice to embed multi-morbidity reviews. And very simply, our aim was to support Manchester practices to embed really proactive holistic care for people with diabetes and cardiovascular disease, but really targeting those reviews to people who'd not been seen for the longest and those who were most at risk based on clinical disease parameters. So we tried to make this as kind of simple as possible. So we split the ask into three. The first was we defined a population for each practice. So, of course, if practices wanted to run with this across their whole long-term condition register, then absolutely brilliant. But we felt that that was unrealistic, and we defined a population. But we didn't just go with QOF lists. We asked practices to really focus on patients who had the poorest disease control. So that was some clinical parameters designed by our specialist clinical networks, or determined by our specialist clinical networks, or who simply just hadn't been into a GP practice for a review for more than 18 months. Then we asked each GP practice to kind of plan how they were going to implement these multi-morbidity reviews, and then to start to implement them for this defined population as a minimum. I know that people with just diabetes technically only have one long-term condition, but when we looked at the data, the number of people with diabetes who are also on hypertension, lipid, respiratory, QOF registers as well, there was just a huge crossover. So we decided that this seemed to be the most simple approach. And the aim is to get practices to think about the proactive and holistic care that colleagues on the call had described, to build on the learning from COVID around making every contact count, ultimately to improve patient experience so people aren't traipsing in and out of our practices. And, let's be honest, given the pressure that general practice is under, we wanted to support practices to optimize their efficiency as well. But we really recognized that this population that we were asking our GP practices to work with and to implement these multi-morbidity reviews in was by its very nature probably the hardest people to get into practice. So we also built in some work with our local care organisation at a neighbourhood level to really promote a neighbourhood and a community focus to improve uptake. So when I was thinking about what I wanted to share, it was really thinking about what our enablers were to getting this off the ground and being able to deliver this scheme for Manchester General Practice. And actually, it all comes back to the team that we had at Manchester CCG and now within the Manchester Integrated Care system. Around bringing together clinical leadership, so GPs, nurses, other clinicians, with our primary care colleagues, our business intelligence team, our quality team, our comms and engagement, and then really using that kind of skills and expertise to drive forward quality and innovation for general practice. And out of this group, the key enablers for our practices were possible. So we developed a suite of EMIS resources, so some data searches to identify target populations. We developed a template for multi-morbidity multi-morbidity reviews. So some of our practices subscribe to Arden, so they could continue to use that template if they wish, but not all of our practices did. So we also created a bespoke local template. We created an achievement dashboard so that practices knew how they were doing. And we run monthly drop-in sessions so that practice managers can really troubleshoot in real time rather than wait till the end of the year when it's too late. And then the kind of other really important aspect was to develop long-term condition dashboards. We felt that it was vital that primary care got better data. So we've developed a diabetes dashboard for Manchester GPs, and we are about to launch a cardiovascular disease dashboard. And of course, you can interrogate these by geography, so by your practice, by your PCM, but you can also interrogate them by protected characteristic and by disease parameter. So it gives a huge wealth of data and information that we just didn't have before. And I've got an example on the next slide. And I think the final thing is funding. We absolutely needed to adequately fund our colleagues in general practice to embed this approach. And, we took a quality approach, a quality improvement approach. We were aware that this was a new way of working, and we really wanted to support general practice to be able to plan, to embed, and then to be able to fund the longer appointment times and the different skill mix that delivering these multi-morbidity reviews would require. So this is a snapshot of our diabetes dashboard, and I won't go through this in any detail, but down this side on the left you can see the different clinical parameters like BMI, blood pressure, for example, and along the top you can see ethnic group, and then you can see RAG rating of achievements there, and you can just start to see when data is laid out in this way how easy it is for our practices to think about their population and these reviews in a really different way. So last slide. I'm really, really aware I am talking to you about something that we are in the middle of trying to deliver, and I don't have any outcome data yet. Our focus over the last 6 months has been to support practices to implement and to deliver these reviews as part of the scheme as a whole. And actually what we are starting to see is that as we are doing more reviews, which is absolutely what we wanted our practices to do, and as we are seeing people who haven't been in practice for the longest, our clinical parameters around diseases, so for example, our average HbA1c, they're actually deteriorating. But as we start to then put clinical interventions in place, what we're expecting in year 2 and year 3 is that we start to demonstrate those clinical improvements. And we have a really robust evaluation approach planned that will start in Q3 of this year, so that we learn as much as we can from the year so far, and that we can really start to incorporate that learning in future years. But we will include feedback from practices and patients about how they found the use of multi-morbidity reviews. We're just trying to work out what we can use as benchmark data to compare ourselves with others against. And then we have that really big question that does this targeted approach and use of multi-morbidity reviews really start to tackle the health inequalities in a way that we're aiming to do. And of course, then we've got an ambition to spread and share this work across our integrated care system and beyond. And I'm really grateful to have been invited here to talk to you today. So thank you so much. And I'm handing over to Rachel.
Actually, I think you might be handing over to me. Is that right, Rachel? Just
Yeah,
to sum up. And, so I think we've set before you a kind of vision of how we think primary care could improve to meet the changing needs of the population. We've told you about some of the strategies and tools that we've developed to try and help people make those changes and implement the change. But we've also told you about some of the issues that we're finding in trying to make change. And finding those issues isn't their problems, we're not denying their problems, but in a way that's positive learning. That's what we need to do to understand what are the things that make change difficult, because in that way you can begin to learn and improve and develop strategies to overcome the problems. And then Claire has shown you how some of these ideas and the way they've approached this problem in a very strategic way in Manchester, in a way I think is very exciting. So now we're going to hand over to you and try and look at some questions, and Rachel's going to chair this bit of the seminar.
Great, thank you very much. We've got some great questions in the Q&A, so thank you for those. I'm going to start off with the first one, which a couple of people, Paolo and Stephen, have both referred to. How can a template adequately capture the nature of a conversation between a patient and a clinician, which might move in unanticipated directions? Is it sufficiently adaptive and flexible? And Stephen asks as well, or comments, that it feels like templates on holistic person-centered care might be contradictions. So who would like to answer that? How about Chris?
Thank you. I think that's a really good question and a real tension. I think that templates are so embedded in general practice today, it's hard to imagine people not using a template in the sense of a checklist. That these patients are so complicated. There are so many things to think about. If you just went in a kind of freewheeling conversation with people without any kind of list of things you wanted to cover, then you would miss important things, particularly some of the things that are important to practices because they're part of the QOF. On the other hand, templates can become a tick box exercise. So what we've tried to do is to say, well, templates are here to stay, but can we use templates to encourage a holistic approach? So our template starts with, what do you most want to talk about? Use the template to encourage the healthcare professional to be patient-centered and flexible, and ask the patient what they want to talk about, what their priorities are, what their needs are, and involve the patient at the end in making a plan. So we think we can use templates to encourage I know it may sound a paradox, an unstructured conversation.
Richard.
Yeah, I mean, I completely agree that we're torn between this idea of wanting to personalise and be reflexive and move in the moment. I think that templates, what we need to be thinking about is 10 years' time or 5 years' time, what kind of interactive tool the individuals and their carers will be working with practitioners. So your templates are really just the start of a journey where patients are holding their own record, they're inputting their own, they're managing their own chronic disease, and when they can't, they're supported to do that. So I think that one of the problems with this research project that I'm part of is that we were kind of asked to do this spreading thing, but actually there's so much developmental work to do to get these templates using state-of-the-art technology so that you can embed the idea of what a shared understanding is with that person, that also links to those key evidence-based things. We don't know how to do that, but we need to work really closely with tech on this to make the best kind of template. And related to what Claire has shown, there's a set of other things that we need to work on. So there's the dashboards that you've talked about. There's the intermediate bit between that, which is a management system for the whole practice and the PCN to be managing this seamlessly. That's only just supported. So you've got the whole team linked to a group of people who need this kind of care. So that kind of top-down development can then be supported from a bottom-up enthusiasm and a set of incentives, and I think that's what we need to be moving towards.
A linked question also: do you think the power dynamics between healthcare professionals and patients may be a barrier to more of a partnership approach, which I guess would be trying to avoid that tick box collection template approach as well? How can we truly partner with patients? I was going to come to you, Cindy.
Thanks, Rachel. Yeah, I think definitely it can be. And I think some GPs and some of the ones that I interviewed for the 3D project were very aware of this and aware that it was also to some extent beyond their control to change that, because it depends on the expectations of the patients as well. And that's why I think, in Maxwell, we're really trying to beef up that patient engagement aspect and get their voice heard in implementing the intervention. But it is difficult. And I'm also very aware that GPs and nurses, they are struggling with this limited appointment time, and they have to fit in certain things that they need to. And so I think the power dynamic is also very much about the tension between the two agendas that Chris referred to before as well.
Thank you, Cindy. There are quite a few questions in the chat about the dashboard, Claire, and how that's developed and where the data for it comes from. I was wondering if that's something that you could tell us a bit more about.
Yeah, sure. And it's where I wish I had our BI experts. So we have an absolutely incredible BI business intelligence team in Manchester, and I take absolutely no credit, because once you describe an idea to them, they make it happen. They have found a way through a data warehouse of using codes that they come out of EMIS at a patient level, and then they recycle through their data warehouse, and then they can put it back in these absolutely amazing dashboards, which they host on a platform called Tableau. I think we started this work in our COVID vaccination program, where we really wanted to look at the different ethnic groups in our city who were having different uptake rates of vaccination, and we've applied that learning now through to long-term condition management, because the wealth of information that we get when you look at diseases cut by protected characteristics and other lenses is just so different than if you were to just pull a search off EMIS at a practice level. I think once the BI team have learned this new way of handling our data, it means that the opportunities are kind of endless now in terms of the dashboards that we can develop. The BI team in Manchester is wonderful, and I think that they would always be willing to share with other areas in the country the work that they've done.
Thank you, Claire. So a couple of questions in the chat about measuring the impact of the implementation of PP4M. So one asks, are impact measures of interest to different stakeholders, patients, funders, healthcare professionals, carers, all included? This might demonstrate stronger impact of the intervention even when it's not easily measurable. And another question that's related, which says that from using multimorbidity templates, there's been a feeling in their practice that it increases workload, and whether that's something that we have any information about or there's good evidence about. Chris, I'm going to ask you to answer that one.
I think it's important to say that the current studies we're doing are not designed to measure the impact. The way to do that would be like a randomized controlled trial, which is what 3D was. This is more about some of these things are good ideas and they were hard to implement, and how can we help people implement them rather than trying to prove that they work, because we don't have control groups to compare. But having said that, yes, certainly we're conscious of what matters to different stakeholders, which is why we're trying to take evidence from staff, from patients. We're looking at workload issues, numbers of consultations. In this study, we can't prove what it would have been like if we hadn't done it. So it's a different kind of study, but certainly we're providing data that helps us understand what's going on and what's difficult and what's working well and what isn't working well.
Richard.
Yeah, I mean, I'd just like to add that I think we can look at impact in a slightly different way, and that perhaps there are some things where we choose not to do randomized trials and as the best way of looking at change. And I think if the dashboard is a fantastic way in to look at how far are we reaching into those who are not getting care. So if you're looking at the inequalities angle and looking at a shift towards those people who are engaging who weren't from different postcodes or ethnicities, then you start to look at an impact in a different way. If you put that together with the cost data, so if we collect a bit of cost data in terms of how much it's costing to do things, you can start looking at value and impact, not from a RCT quality of life perspective, but making a judgment as a system. Does it feel like it's, with the numbers, are we making a difference? Do we need to tweak something here and there to make it better?
Thank you, Richard. There are several questions and comments in the chat as well as about the different members of the primary healthcare team, and recognition that there are lots of different people now potentially with the skills to get involved in this work. OT, we mentioned mental health nurses, pharmacists, social prescribers, etc. But then also questions about how do we know who the right person is? How do we work out who's the right person with the right skills for this work? Where do GPs fit into the picture? Someone commenting that some of this is very complex and it's going to end up coming back to the GPs. So how do we engage the GPs back in this work? So any comments on how we unpick all of that complexity? Cindy. You're muted, Cindy. You're muted.
Sorry about that. So yeah, I think there's a lot of complexity involved in this question, and I also wanted to pick up on a comment that I noticed earlier I think it might have been in the chat, about who has responsibility for the person's healthcare. So I think that's maybe the fundamental question. And in the year of care training in particular, the emphasis is on pulling in any member of the team who might be relevant. You know, somebody initially has to identify what the concerns and what the priorities might be for that individual person in improving their well-being and improving their health. But then how it's taken forward from that is very much a multidisciplinary team thing. And it might be that a referral to an OT or a referral to a physio or social prescriber or pharmacist, you know, all of those are on the table. But in a way, it comes back to, you know, who holds that overall responsibility, the overview, and that might be the GP. Many GPs would say that, and many patients would also say that. Some patients, though, would argue and support the idea it was actually their responsibility, and that's part of the argument for having access to their own record and being able to contribute to their own records, be the holder of them. So I think that's a really important debate that needs to be had. Richard.
No, I completely agree, and I think there's two useful things to think about heterogeneity. You know, how different we are as practitioners and practitioner teams, and that you need to organize and self-organize that, who's going to do what, but how different patients are, as Cindy has said, and that, you know, I think the old PAM tool that we've used to look at patient activation is not a good outcome, but it's a very helpful guide to thinking about what level of involvement and engagement individual patients can have in their care. So we need to be able to do both. We need to be really supporting self-care for those that can manage, so there's less work for the primary care team, and that will save time for those who do need support.
Fantastic. Thank you, Richard. I'm really sorry that we're not going to be able to take any more questions because we've reached the end of our time, but fantastic to see so many questions and comments also. And I'm sorry if we haven't managed to get to yours, but I'm just going to hand over to Helen Bolton.
And thanks to all the panel for your presentations and a really interesting discussion today. And thanks to everyone who has joined us today. I'm just putting this last slide back up for you. If you want to keep in touch with us, there are a number of ways that you can do so. We will be sharing the recording, the slides, the transcripts, and so on with you all in the next week or so. There are a few questions that have come in the chat. Somebody's asked, could we get a certificate, CPD, I think, certificate? We didn't think about that in advance, but I can look into that. I'm not sure is the answer to that one, but if we can, I'll find out. So I think that's it. We hope that you enjoyed the webinar, and we hope that we will see you at a future CAPC event. Thanks very much, everyone.